In today's Alright, road 250 today we're going to do some questions. Alright, so first one, micro. A 12-year-old Taiwanese immigrant boy comes to your office with a bilateral swollen parotid glands. A bilateral swollen parotid glands. Great job, Pete. Difficulty swallowing and a headache. He's presenting with a fever, coryza, and mom says that he has appeared to be in a down mood for a few days. If the child's symptoms are left untreated, what is the most serious complication that is associated with this viral infection? We'll take a look at arthritis, cholecystitis, orchitis, or pancreatitis. So what does this boy have? Yeah, bilateral swollen parotid glands. My grand would be goods.
Pancreatitis would be my answer. But I think I'm wrong.
So what does he have? Bilateral. It's a child. Foreign. So if he's foreign on on this kind of test, what are we automatically assuming?
The mumps?
There you go. Bilateral swollen parotid glands, mumps. If he's foreign, we can assume this kid didn't get vaccinated because you don't see mumps in our country anymore, really. What is the sequelae for mumps if it goes untreated? Can lead to infertility.
So
Orchitis.
it's a orchitis.
Orchitis. This child is presenting with mumps. The most severe complication associated with is orchitis, which can lead to male sterility. Although mumps vaccination is present in the routine MMR vaccine, the question stem states that the boy is an immigrant, and one can assume that he may not have received all his vaccines. Glomerulitis, malarial glomerulitis is associated with strep pyogenes, cholecystitis is associated with gallbladder bile infections, and pancreatitis is also a complication of mumps, but it's not as severe as orchitis. So you were right to a degree, Yash. All right. 45-year-old man comes to the... Oh, by the way, if we come up on your question, let me know, and then you guys can dictate it. So is this either of your guys's?
My question.
Okay, go ahead.
45-year-old man comes to the physician because of severe nausea, vomiting, and diarrhea that developed over the last 48 hours. He's diagnosed with viral gastroenteritis and is administered a medication intravenously to reduce nausea. A few minutes after the administration of this medication, he reports that he has severe neck pain and can't turn to his right side. His head is forced down and to the left, and he has a visible spasm of his sternocleidomastoid muscle. His presentation is most likely due to exposure to which of the following medications?
So you've got torticollis. Okay, so you're not... Diphenhydramine is what you give to treat that.
Yes.
They gave me Benadryl. Domperidone. Some kind of antipsychotic, which could cause that. Metoclopramide. Oh, okay. So you've got metoclopramide, which is a prokinetic agent. And this guy's got GI symptoms. And if that one's associated with antipsych meds, then it can cause tardive dyskinesia and extrapyramidal symptoms. So I guess maybe C. Ondansetron.
It's given for chemotherapy drug, right?
What's that?
Isn't that
Isn't it antiemetic?
given?
Which one?
Ondansetron?
Ondansetron is a serotonin receptor
Antagonist.
Agonist or
Antagonist.
Antagonist. Yeah, for vomiting.
Mm-hmm.
And then pantoprazole is a PPI.
Yes, I see.
The answer is C.
Correct. So both domperidone and metoclopramide are dopamine antagonists. The difference is that domperidone isn't absorbed into the CNS, so it doesn't cause the extrapyramidal side effects that metoclopramide does, because metoclopramide is centrally acting.
Gotcha. All right. Is that of you guys?
I think that is also
Nope.
Yes. An 11-year-old boy comes to the physician after developing fever, headache, and neck stiffness over a period of several weeks. Additionally, he has joint and flu-like symptoms. His mother reports that several weeks back he was bitten by a tick, and shortly thereafter had a target-shaped rash on his abdomen. They did not seek medical attention at the time. He has a low-grade fever of 38.2 degrees Celsius. He has mild neck stiffness. Examination of his cerebrospinal fluids demonstrates a lymphocytic pleocytosis. Microscopic examination of his CSF is likely to reveal which of the following.
Alright, so we're talking Lyme.
B. Yeah, it's not B.
So Lyme is Borrelia burgdorferi.
Mm-hmm.
If I remember from first aid right, BLT are the spirochetes. And that's Borrelia burgdorferi, Leptospira, and Treponema pallidum. So it's got to be D or E.
Mm-hmm.
I'm talking spirochetes. The actual film is visualized by Darkfield. No, that's Treponema, so
D.
I'm guessing E with the Giemsa stain.
He is
Boom.
correct. You guess what the other ones are? We already said D is treponema.
Gram-negative Diplococci, is that Neisseria?
Yes.
Budding yeast with captain's wheel formation.
That's one of the fungi. Not
Coccidioides?
Yeah, that one.
Paracoccidioides.
Yes.
Paracoccidioides, yeah. And then I think the top one is either nocardia or
Actinomyces.
Actinomyces, yeah.
Nocardia is correct.
Depend on if they're was it acid
partially
fast?
Acid fast versus
yeah, right. Good question. With you, Yara?
That's mine. 56-year-old man comes to the physician due to difficulty breathing for the past 4 months. He's diagnosed with hypertension 4 years ago, but has not been compliant with his medication. Further questioning reveals that the patient uses 3 pillows in order to sleep and has been having cough episodes at night. His vitals show a BP of 147 or 94, pulse at 90, and respirations at 13, with temp at 99. Physical exam reveals an S3 gallop over the heart apex and a displaced PMI. Which of the following is the most likely pathological mechanism of his orthopnea? So it's a review back from what we did this week. So does it increase your central venous pressure? Does it increase contractility of the heart? Increase sympathetic activity, or increase venous return? So first of all, what does he have?
CHF and pillow orthopnea.
Correct. So the key things you want to look for is that S3, his hypertension, and then the 3 pillows. So what causes orthopnea?
You got backup.
Right. So is it left side or right side?
Left side of heart failure normally.
So what would an increase in central venous pressure do?
It'd be more difficult for the heart to pump against it.
Right, but where is the central venous pressure? Where would you see the backup last before the central venous pressure?
Right.
Right
Right
side,
atrium.
so right atrium. So you're going to see more pitting edema with central venous pressure increased. How about heart contractility and sympathetic activity? What are those two things?
Well, I would think those would be decreased because
Right.
you're having a pumping problem.
Right. In his case, he's got probably a chronic heart failure, not even just an acute. So at those point, those things are not going to be very effective.
So it's increased venous return, so increased preload.
Correct. Yeah. So the answer is D. Patient has heart failure due to left ventricular abnormality, and this is orthopnea is defined as shortness of breath. So typically the heart failure pulls the blood in the venous circulation, but when you're sleeping, everything flows to the heart because of gravity. So there's an increase in the venous pressure, does not lead to orthopnea. It'll probably lead to pitting edema. That was answer A. And then B and C are just compensatory mechanisms in the early stages of heart failure. So because of the pooling of the blood in the heart, it has a hard time. And like I showed yesterday with PEES, hydrostatic pressure in the lungs, it would cause that orthopnea.
Gotcha. All right.
All right, so this is also mine. A 28-year-old African-American female presents to your office with extreme fatigue and bilateral joint pain. Serology demonstrates the presence of rheumatoid factor along with anti-Smith and anti-DNA or double-stranded DNA antibodies. A VDRL syphilis test is positive. You order a coagulation profile which reveals normal bleeding time, normal PT time, and a prolonged PTT, but a normal platelet count. Further evaluation is most likely to reveal which of the following: Palmar rash, HLA-B27 positivity, factor VIII deficiency, history of multiple spontaneous abortions, or immune thrombocytopenia.
So she's got some sort of autoimmune disease. So it's not C because she would have to be a male, and her PT would be increased, not PTT.
Correct.
Immune thrombocytopenia would mean her platelet count's decreased, so it's not E. So history of multiple spontaneous abortions, that would be that's associated with hypercoagulability. And what is that one called?
All right, so first of all, what does anti-Smith and anti-double-stranded DNA antibodies reveal?
Lupus.
Lupus, right. So in lupus, do you commonly see VDRL syphilis test as positive?
Yeah, it can happen.
Okay. And
so Palmar rash would be out because she probably doesn't actually have syphilis.
Correct. So that leaves you with just B then, right? Is that what you're saying is the right answer?
Well, because I know it was an autoimmune disease. I was trying to knock out the other ones.
Okay, so
is it B?
No, because lupus isn't with the HLA-B27s.
Yeah, that's
pair ones.
Pair. So you have your ankylosing spondylitis,
psoriatic arthritis,
irritable bowel,
IBS,
and reactive arthritis for those HLA-B27. So the correct answer in here is D.
Oh, okay, so
it's the antiphospholipid syndrome. So that's commonly seen with SLE. So in this case, you're going to look and see that the anti-cardiophilin antibodies, which is what caused the VDRL to be false positive, and then the lupus anticoagulant can cause a prolonged PTT. So this is typically seen secondary or primary, and most likely in syphilis. Or lupus, and lupus. So
I didn't see your little thing down here.
it's all good. It basically says the false positive VDRL due to the anti-cardiophyllin antibodies that can increase the PTT. So it's antiphospholipid. That's the correct answer.
A woman is pregnant with her first child and does not receive prenatal care. When the baby is born, a small sacral tuft of hair is noted, and ultrasound demonstrates an underlying defect in the dural sac. This presentation may have been prevented by maternal supplementation with a particular nutrient. Which of the following would be seen in an adult who is deficient in the same nutrient? Dermatitis, night blindness, hypersegmented neutrophils, numbness and tingling, or poor wound healing. So, poor wound healing would be vitamin C. Well, obviously she's talking about folate.
Yeah, night blindness, vitamin A.
Yeah. Numbness and tingling is vitamin B6. Dermatitis is a bunch.
Dermatitis is all of the B vitamins. Numbness and tingling is
so is
3 and 6. So C. I think C is 9 and 12.
Correct.
And folate. Oh, wait, yeah, this is 9. Folate is 9, right?
Mm-hmm.
The answer to this one was also C.
C. Hypersegmented neutrophils.
Right on. All right. A patient is seen in the clinic. He has an autosomal recessive disorder that resulted in a deficiency in tyrosinase activity in specific cells. He appears pale with light blonde hair and blue eyes, and notes that he sunburns easily and that his eyes are very sensitive to light. The cells most involved in this condition are derived from which of the following germ cell layers? Ectoderm, endoderm, neuroectoderm, neural crest cells, mesoderm, neuroectoderm, non-neural crest cells. So this dude is albino. So she must be talking about melanocytes.
Which is the part of the motel bed pass mnemonic for... Shoot.
Gee, who came up with that stupid mnemonic?
A mnemonic that didn't
neural crest cells, I believe. What?
I said a mnemonic that didn't work so far.
What do you mean?
Hotel bed pass. It didn't work for her. It was a failed mnemonic, so she needs to come up with a better one.
I remembered that it was part of the mnemonic.
I came up with it.
Well, I'm saying, but for her, it didn't work.
It's the M in motel bed pass. Melanocytes.
Okay.
So it's neuroectoderms, neural crest cell C.
Yes.
And we just got one more. Following up with Divya's presentation this week. A 33-year-old man from Mexico comes to your office complaining of a 2-day fever, sore throat, and shortness of breath. On physical exam, the patient is found to have cervical lymphadenopathy, thick gray tissue-like covering over the tonsils. Which of the following types of culture should be used to determine the organism affecting this patient?
Well, it's not B.
Because what gets stained on B?
Bordetella.
Bordetella, right?
Bordetella doesn't. It's not chocolate agar with factors.
Well, what does this guy have?
Diphtheria?
Diphtheria. It's the Loeffler's medium. Tell you right.
Yeah. Oh, actually, it's supposed to be D, but yeah, Loeffler medium.
Oh.
No, I mean, it just up here I put B like an idiot. But yeah, you have the correct answer. Patient presents with cyanobacterium diphtheria. These are the medias which can be used to clinch the diagnosis. Lowenstein Jensen agar is used for Mycobacterium TB. Borde Jeju, whatever, is Bordetella process. Chocolate agar with factors 5 and Phoenix is to culture Haemophilus, and Thayer Martin's medium is to culture Neisseria gonorrhea.